All right, Lifting and Moving, Chapter 6, Part 2 of 3. Talk about some patient moves. We have basically emergency, urgent, non-urgent type moves. Emergency moves, the patient must be moved to a safe place before you have time to complete an assessment. Such as our car's on fire, you have to get them out of the car before you can perform any emergency treatment on the patient. You got to get them out now. And we have urgent moves. The situation allows for abbreviated version of an assessment and spinal immobilization, such as the patient's been trapped in a car, but you're able to put a C-collar on the patient and place them on a backboard. And then we have our non-urgent moves. Moving the patient to a stretcher after a normal patient assessment and initial care. This is the most common type of move that we do, is the non-urgent care or non-urgent move. So why use emergency moves? The situation may require an emergency move, such as a hazardous scene. You need to treat and care of life-threatening conditions require repositioning, such as a patient in cardiac arrest on a bed, we need to move them to a floor. Or they're sitting in a rocking chair and they're unconscious and they need CPR, you need to move them to the floor, because it's not going to do you any good to do CPR on somebody that's sitting up in a rocking chair. I've walked into nursing homes and see it being done. CPR in a rocking chair. Doesn't work. Or the patient needs to be moved to reach a critical patient. Non-critical patients are in the way of the critical patient. Maybe a motor vehicle collision and one of the critical or non-critical patients has fallen over on a critical patient. You need to get the non-critical patient out of the way to reach that critical patient. To minimize or prevent aggravation of a patient's injury, move the patient in the direction of the long axis of the body. Example, drag them in a straight line, don't drag them sideways. There are several rapid moves that can be used that involve dragging them by their clothes, by their feet, by their shoulders, by a blanket, or even a sheet. So emergency moves when the car's on fire. First, you're going to place your arms through the armpits and support the head against your body. You're going to drag the patient from the seat to a safe location. Or you're going to first move the legs clear of the pedals, rotate the patient so the back is towards the open car door, and then pull them free of the vehicle that's on fire. With emergency moves, if you're alone, you can use a drag to pull the patient along the long axis of the body. Use techniques to help prevent aggravation of the patient's spinal injury. The clothes drag, the blanket drag, the arm drag, the arm-to-arm drag. Some other emergency moves, the clothes drag, the blanket drag, upper right-hand corner, lower left-hand corner, you have the arm drag, and then in the lower right corner is you have arm-to-arm drag. And this one works well with a second rescuer in lifting patients, where the second rescuer gets under the legs and helps pick up the patient. Urgent moves are required when the patient must be moved quickly for treatment of an immediate life threat, such as altered level of consciousness, inadequate ventilations. The patient needs support for their inadequate ventilations or breathing, or your patient needs treatment for shock or altered mental status. Or the scene factors cause a decline in the patient's condition. And with urgent moves are performed with spinal precautions in place. We would try to put a C-collar on them, but we very well may have to maintain manual stabilization in order to make that urgent move and then place a C-collar on the patient. We can also use a backboard, an urgent move with spinal precautions, moving a patient to a backboard from the ground. You notice the female that has manual stabilization of the patient's head and 3 people down the axis of the body. They're going to use this log roll maneuver, placing the patient on their side. So they're going to roll the patient towards themselves on the count of the person that is in control of the head. It's one swift movement altogether. So we place the backboard next to the patient, then we log roll the patient back up onto our thigh area and pull the backboard underneath the patient, then log roll the patient back on the backboard, secure the patient to the backboard with straps, secure them to the stretcher. And this entire time, you want to keep your back straight, lean from the hips, use your shoulder muscles to help with the roll. An urgent move with rapid extrication. Here we have a patient that has critical injuries and we need to remove them from with a KED. And the KED is an item that we use in the non-urgent move, because if we take time to put it on, it can cause significant delays possibly. We're going to manually stabilize the C-spine if we use it, apply the C-collar, and with a series of commanded moves, the patients rapidly move to a backboard. With the urgent moves, rapid extrication technique is an urgent move and should only be used if the urgency exists. The patient in an urgent move can be moved within 1 minute. The technique increases the potential damage if the patient has a spine injury. We have to work as a team. They're complaining of back pain, severe back pain, numbness, tingling in their arms or legs. We may have to use this urgent move, but it could cause more problems, but we need to be aware of that. And we need to look at all options before using the urgent move. Do we have enough time to maybe have a rescue crew come in and take the roof off the car, take the doors off the car? Some non-urgent moves used when there's no life threats. It's used with both scene and patient are stable, no life threats. It allows for initial assessment and manage of the patient. and it frequently uses a carrying device, such as a wheeled stretcher. The team leader plans for the move, gets the personnel together, identifies obstacles, identifies the need for the equipment, and the path that you're going to move the non-urgent patient. Here's a non-urgent extremity care or carry. Even if a non-urgent situation avoids spinal injury or extreme extremity fractures, it can be used both in an emergency and non-emergency move. For those with no suspected spine injury, go ahead and use this, especially if they're supine or sitting. This type of move, this non-urgent extremity carry, is helpful when the patient's in a small area. One EMT's at the patient's head, the other patient at the patient's feet. And we're going to coordinate the move verbally. This is one of those moves where the person at the head still is in control and has the communication, but with the person that is walking with the legs, they can still communicate back and forth, but the person at the head is calling the shots. Here we have a non-urgent move at the hospital called the jaw sheet method. I'm going to use a sheet to move a patient from the patient's bed to the stretcher or from the stretcher to the hospital bed. The thing you got to remember about this is most stretchers are covered with a paper type of sheet. This was real common back when we were using cloth sheets, but the cost got astronomical for cleaning and disinfecting that had to be done off site. So with paper sheets, be careful that the paper sheet doesn't tear. So in picture one, the EMTs are communicating with the receiving ER people. ER people reach across their stretcher to grab one side of the stretcher sheet. In scene three, the hospital people start pulling the patient across while the two EMTs, they don't have to fully pick up the patient, but they need to guide that patient off the stretcher. Usually the stretcher sits about 1.5 inches, 2 inches higher than the bed. So you want to make sure that the patient doesn't fall down onto the bed. And then in the last picture, they've moved the cot and they're giving their report about the patient. Geriatric patients. Skeletal changes can cause brittle bones and spinal curvatures, present special challenges. Be sympathetic and compassionate. Anticipate the need for padding in the voids with blankets and or pillows. If you're putting them on a backboard, now we have two different types of skeletal changes. The left picture is kyphosis. Kyphosis is also known as hunchback. Then on the right-hand side, we have spondylosis. Spondylosis is the one that you might see a person that is walking. They can walk. They may have a slight limp, but they are leaning off either to the right, such as this patient, or to the left. But they're not able to move from one side to the other. Once the spondylosis takes effect, it keeps them on that side permanently. Another situation we run into is the bariatric patients. Roughly, as of June of 2012, there were roughly 72 million Americans that are obese, and 18 million of these are morbidly obese. With bariatrics, the management of it's the term bariatrics is the management of obese people. And if you look, it's estimated that by 2030, more than 42% of America will be obese, greater than 100 pounds overweight. The doctors are now reporting during COVID with home confinement that on the average, each American is gaining 15 pounds because of eating at home, not getting out and getting exercise, uh, social distancing, not going to the gym, not working out. So be very aware that you're bound to come across obese patients. Always remember, get help when needing to lift obese patients. And out of the hundreds of millions of Americans, there's about 20 to 25% that are children. And nowadays, we actually have bariatric ambulances, and Dallas Fire Rescue does have a bariatric ambulance. I forget what station it's assigned to, but I know it's south of 30, but it's special called out. These bariatric ambulances have stretchers and equipment that are produced with higher capacities, and they have some various features. That the general features are the head and the foot end. They have strong metal frames and make it easier to push and to pull and to lift. They have hinges at the center that allow for elevation of the head and the back. And they have guardrails that prevent the patient from rolling out. Uh, Before we had bariatric stretchers and ambulances, if we had a bariatric patient, we would have to dismantle the back of the ambulance, the cot out, take the mounts for the cot out of the back of the ambulance, and call for an engine company or a truck company to come and help us load the patient. We'd have to put them on a tarp and take them all the way out to the ambulance in a tarp. Now we have other ways of getting large people out of small spaces, and then put them on the floor of the ambulance. It was very it was embarrassing for the patient, but we had no other options. Nowadays, we have mechanical ambulance lifts that are a lot more common in the United States than they were even 5 years ago. And if you look at the picture here, one of the assists, mechanical ambulance lifts, the cot, it's a big long metal rod that comes out and connects and goes underneath the stretcher, picks up the stretcher, and then pulls it into the back of the ambulance. Some of them have a winch that's at the front of the ambulance on the inside, and they can winch up the cot that's on a ramp. So there's many ways of getting the patient loaded into the ambulance that brings more dignity to themselves. The bariatric stretchers, they're specialized for overweight or obese patients, wider wheelbases for increased stability, handrails on the foot, handrails at the head, the ease for moving the patient, rolling the patient, and then lifting the patient. So this is the end of part 2 of 3 parts of chapter 6, lifting and moving.